Welcome to COVID Questions by the Numbers. This town hall is a series to address pandemic-related topics in partnership with UPJ, the Tribune-Democrat, and In This Together Cambria. Tonight, we will explore the numbers, statistics related to COVID-19. You can ask questions in the Q&A button below here in Zoom. We're also live streaming this town hall on In This Together Cambria's Facebook page, where you could ask questions there as well. Mr. Chip Minemyer, editor of the Tribune-Democrat, will moderate this discussion. Tonight, we have three experts who will address COVID by the numbers. Paul Ricci, a freelance statistician who tracked local COVID-19 statistics since the beginning of the pandemic. Dr. Jill Henning, an associate professor of biology at Pitt-Johnstown, and Tulsi Shrivastava, business intelligence analyst at Learning Sciences International. It's my pleasure to introduce Mr. Chip Minemyer to begin this town hall. Chip?
Thanks so much, Eric. It's a pleasure to be with this group and be back with everybody in the audience. This is our third go round. I think every session we've done has been very interesting and very useful. And this one will be just as interesting, I think, as we get into the numbers of COVID-19. It's an interesting topic, and we're going to start with why are the data surrounding COVID so important to our understanding of the pandemic? And we're going to start with Tulsi, I believe.
Hi, thank you so much, Chip. Right, so with so much information circulating on social media, it can be difficult to gauge what is accurate, but numbers and raw data hardly ever tell a lie. So with accurate reporting, we can combat the spread of misinformation on social media, we can better prepare healthcare workers, and we can also ensure that people understand the severity of COVID and also understand the vaccines. The better we understand the data, the better we can take care of ourselves, and the quicker we can take measures to pull ourselves out of this pandemic. Some of the topics we'll be covering today are why we use 7-day averages as well as other measures. We're going to go into Pennsylvania trends, and then we're going to go into our local county city trends. We're also going to look at why the misconception of flu and COVID, misconceptions revolving that, as well as the ripple effect. And I'll hand it back over to you, Chip.
Thanks so much. I think you'll find all those topics interesting. I'll remind everybody who's with us tonight that you can pose questions in the Q&A box on the screen or through Facebook Live, and we will try to our best here and there throughout the program to get your questions before the panelists and get them answered. And the first question we have, we're going to start with this. As the slide shows, one statistic we use to discuss coronavirus cases is the 7-day average. What does this number tell us that we might not get from a single day's data or some of the other ways we might calculate?
Hello, my name is Paul Ricci. Okay, so why we use 7-day averages. At the top graph shows the number of daily cases that we've had in the county since the pandemic began. And we can see that there are lots of, it's very jagged and lots of peaks and valleys. We can see, so this is partly due to the fact that reporting and testing is always slower on the weekends because it's the weekend and holidays. And we use the 7-day average to show that, to smooth out the curve, and we can better see, it makes it easier to see trends in cases and testing without all the normal hiccups that may happen in the reporting process. So, like we can see in the graph below, that the red line shows the trend in testing. So here we can see that there was a high amount of testing, say early in the pandemic, in the first few months. The cases necessarily did not correspond, the number of new cases per day did not necessarily correspond to this rate of testing, but so say starting in November, that we can see that the rates in testing and new cases do correspond to each other, with certainly a high peaks in December and have since leveled off, but are still above the level that they were before, before November. Okay, so Tulsi, would you like the next slide?
Yeah, sure. Thank you, Paul. And one of the terms that you might hear today is going to be population adjusted. Now, what does that mean? When we look at data across different populations and we want to compare one county to another county or one state to another state, all of them have different populations, so we're going to get different numbers. When we adjust for population, that means we take a standard number of 100,000 and we adjust the number so it's easier to compare to one another. We kind of standardize it. And another term that you're going to be hearing is called case mortality. Case mortality is an estimate of the risk of dying when someone tests positive for the virus. So this is going to be the number of people who actually died from the disease over the number of people who were diagnosed. This helps us understand the severity of the disease as well. The higher the rate, the case mortality, the higher chance of, the higher the death of chance of dying from COVID. So I will pass it back over to Chip for the next question.
As you can see, we're going to look at some Pennsylvania demographic trends now. How has Pennsylvania been faring based on the numbers? How do we stand up compared to the country? Is there a difference between males and females? And do we see a difference ethnically in terms of COVID cases?
Okay, so like here, so when we're talking about race and coronavirus in Pennsylvania, you know, we only have data at the state level, not at the county level. In 40% of the cases, the race of the person is not reported by the Pennsylvania Department of Health. However, race is reported for all of the deaths, which are easier to track than cases. So looking at the table at the right, we can see that African American and white mortality rates are similar, followed by Hispanics and Asians. But those in the other racial categories do have the highest mortality relative, which is almost higher by an order of 5. So this is just what the state has reported. And so for gender will be, so for gender, we see that, you know, gender is reported for almost all cases and for all deaths. We can see that in terms of cases, there's about 10% more cases amongst females than males, but males are 15% more likely to die if they catch the virus. So overall, the overall death rates are, I mean, it's slightly higher for men because of these differences.
Thank you.
So, and then, okay, zip code. Okay, the local trends.
Chip, do you have a question about the local trends?
Yeah, I mean, we're interested obviously in knowing how Cambria County, you know, how the numbers fare in Cambria County. We've talked about Pennsylvania. Can you talk a little bit about how the numbers look within Cambria County and maybe with different areas of Cambria County comparatively?
Okay. So like here, we can see that the state overall does lag behind the US when it comes to testing. Only say there have been enough test results to cover only 34% of the state's population, while there have been enough. So at the national level, there have been enough test results to cover 89% of the US population. But of course, the same person is often can be tested more than once. This probably explains why the positivity rate is much lower nationwide than it is in the state. These testing rates are generally higher for the county, but and the positivity rates are also higher. So, okay. And yep, so this is what, so then they are higher in Ebensburg. I'm sorry, I missed something. And they are higher in Ebensburg because of the presence of the county jail.
And then we have a greater look at Cambria County from this Pennsylvania dashboard here. And we can see the 15905 zip code has the most cases, followed by 15904 and Ebensburg. So Johnstown and Greater Johnstown, Westmont, Geistown follow right here. And Ebensburg is right around here.
Okay, so now to answer Chip's question about how Cambria County ranks in relation to the rest of the state, using the population adjusted rates for cases, we see that the county now ranks seventh in the state with about 8,131 cases per 100,000. We rank eighth in the state in case mortality. Currently, our rate is 3.38%, which is double the US rate. In terms of the number of test results, the percentage of test results for the population, we rank 10th in the state in the testing rate. We rank 15th in terms of hospitalizations. We rank 4th in terms of population adjusted deaths, and 4th in terms of the number of patients on a ventilator, which is about 7.68 per 100,000. The good news is we also rank 8th in terms of full vaccinations. Currently, we're at 1,578 full vaccinations per 100,000. And so that means just individuals who've had both shots. So, okay. And then Tulsi will present.
Right, so in this slide, you can see, so we're comparing the zip codes. So we're looking at the zip codes in our area, and then we're looking at testing rate as well as cases per 100,000. We can see that the testing, although it's higher in the region outside of Greater Johnstown, we can see right here, the cases are 40% higher outside of the region of Johnstown. So if Paul, you wanted to elaborate on that.
I'm sorry.
Yeah.
Well,
no,
yes,
you're good.
Well, certainly the testing outside of the region of Greater Johnstown, in the region of the county outside of Greater Johnstown, you know, I define Greater Johnstown as the zip codes 15901 through 15909. So yes, that the number of cases is 40% higher outside of the Greater Johnstown area, but there's only 10% more tests that are conducted, which suggests that there may be lots of other cases that are not being tested, that are not being found outside of Greater Johnstown. So there needs to be more testing outside of the city of Johnstown.
And okay.
Okay, so the next question, often here, it's about super spreader events. So the region did have a large increase in terms of the number of cases, say in the month of December, in the month of November and December. And there was a super spreader event in the middle of October in the area where individuals were not masked with a large gathering. And we can see that the increase in terms of the number of cases is commensurate with that. So, and certainly some other spreader events may have occurred, say, around the Thanksgiving holiday, which also contributed to the rise. And it was, as we would call this an exponential curve. And we can see the trend also in terms of the number of deaths in the county. So the rise in deaths occurred about a week or so after the rise in cases occurred. Okay,
That's
so
good.
We do have, if we can interject just for a minute, a question that's been sent in to us that we'd like to have answered, and I think Jill's probably best positioned to maybe tackle this one. Can you, and it ties right into some of the things we've been talking about, can you discuss the politics of vaccinations? It seems that many seniors 65 and over are willing to get the vaccination, but other age groups are expressing disdain with the entire vaccination process or even the need for vaccinations. How effective will this vaccine program be if this train of thought continues?
That is a great question. And we have so many things to handle on top of tackling the anti-vaccination movement. Back in May of 2020, there was a group of scientists that published a paper in the journal Nature in which they looked at how pervasive and invasive the individuals were associated with anti-vaccination groups or being anti-vaccination in general. And they are in almost all parts of our social media. If you have a group that you belong to because you like Cocker Spaniels, there's someone in that group that also is an anti-vaxxer. So they end up gaining trust, you become friends with them, and then they begin to give you false or misinformation surrounding vaccinations. The goal of this particular series, COVID Questions, is to help to combat that misinformation. When it comes to politics, there is definitely a red-blue divide whenever we're associated with vaccinations, particularly surrounding COVID. And that comes directly from the national response that has occurred prior to the vaccination plan being outrolled. If the head of the household uses improper language when describing something, the children will also follow. So what we now need to see is a massive amount of national leadership, state, local, and regional leadership that will help to continue to talk about the safety, efficacy, and desperate need for the COVID-19 vaccine. The best way to combat misinformation, wherever it's coming from, is with education. So simply by being a part of this type of event, you can take this knowledge that you've gained and impart it onto others. As for the other surrounding political divides, maybe some of our other panelists could also reiterate my point.
Oh, okay.
Any takers?
Go ahead.
We've certainly seen it in places like Readers Forum and messages to the editor here at the Tribune that there's some division over getting the vaccine, just as there was over the existence of the virus a year ago. And I think so we're seeing some of that improve, and I think forums like this hopefully will help people see both the realities of this virus and also the need to get vaccinated as soon as possible. Now, of course, we've been reporting recently that there's not enough vaccine in some cases for folks to get vaccinated. So that might be also a hindrance to moving forward. I will remind people you can ask questions through the Q&A function and also on Facebook Live, and we've got that question from an outside, from a viewer. We're now going to talk about the interesting question of the flu versus COVID. And many have said that we can compare COVID-19 to the flu, but is that really true? If there are differences, what are they? And I believe we'll be starting out talking about that from a statistical standpoint or a data standpoint, if you want to take it from there.
Okay, well, okay, I'm just going to compare. So for a large population, the overall mortality rate. So just comparing the mortality of coronavirus versus the flu. Okay, according to Johns Hopkins, the current death rate from coronavirus right now is 127 per 100,000 US individuals. The flu rate according to the CDC, the rate for the flu was only rate from the flu from the 2019-2020 season last year was only 6.65 per 100,000. So dividing 127 by 6.65 gives us a ratio of 19.11, which basically says that coronavirus is 19 times more deadly than the flu. So yes, you can just also look at case mortality rates, and certainly a similar number occurs. So yes, this is why these, it's important to consider these rates.
And I was going to request Dr. Henning to also weigh in here in terms of the difference between the flu and COVID infection rates.
Right. So just like Paul was saying, when we're talking about how much more deadly it is than the flu, when we look at infection rates, when you think about influenza, and there's a common misconception, if you have the stomach flu, that is not influenza. The stomach flu is a gastroenteritis or caused by several kinds of viruses, specifically enteroviruses, that do not cause the flu. So we're talking about respiratory flu, the kind that happens in your lungs, not the kind that affects your digestive system. So that type of influenza, true influenza, is going to have a short incubation period. Individuals will be exposed and then they will develop symptoms within 6 to 8 hours. Sometimes it can take up to 12 hours. But we're only talking about a day from the time that you're exposed until the time you start seeing symptoms. At most 18 hours, a day and a half. So it's really a short period of time. Therefore, you know that you're sick and you stop seeing other people. With COVID-19, it has a much longer incubation period. In fact, the incubation period is anywhere between 2 and 14 days, with the average being 5 to 7. So the way I like to describe this is that if you needed to remember what you ate for lunch 7 days ago, could you do it? That's what we're talking about. Can you think of every single person that you've came in contact with 7 days ago? What about 14 days ago? So now we're talking about someone who could be pre-symptomatic, spreading the virus between days 2 and the time they start showing symptoms, and they're not knowing it. They're not doing it intentionally. They just are spreading it. So we're having the infection increase exponentially simply because they are not symptomatic almost immediately following exposure. So we have to look at those two scenarios. We're also looking at hospitalization data. Paul mentioned that hospitalization data in our area is high. When an individual is infected and succumb with the flu, most individuals are not going to require ventilator support. We are seeing an overrunning of hospitalizations associated with COVID-19, which is also different than the flu. So we're starting to see that there are some differences between COVID-19 and the flu, other than just its deadliness. It's also its incubation period, the morbidity. It makes people sick and they must go to the hospital much more frequently than the flu or than influenza virus. So comparing COVID-19 to influenza would be like comparing apples and oranges. Yes, they are both fruit. Both of them are respiratory viruses, but they don't taste, act, or sound the same at all. So that's sort of what we can say. The only thing that they have in common is that they are both respiratory viruses that infect our lungs. Other than that, there's very little similarities when it comes to statistics and symptoms.
While we're on the science here, before we move to the ripple effect, let's take another question we just received, which I think kind of follows up well with that from Facebook. How much of and I think, Jill, you've answered this at other sessions for us. how much of the population being vaccinated will it take to start seeing the rates decline, specifically from vaccinations? And I think that's kind of a little twist on the question we've asked a couple of times.
So that is a good question. In order to see herd immunity, which is what that question is asking about, how many people in a population need to be either be protected from COVID-19, either by natural infection or vaccination. The goal of that is 80%. So if we have 33% of a population that has had COVID in an area, in order to reach up to that 80%, we have to get, 40, 46, 47% of those individuals in that area then also vaccinated. So the more vaccinations that we can have distributed, the more shots we can get into arms, the more protected our communities are going to be. And then we're also going to take comfort in knowing that we're protecting our most vulnerable populations. So it does depend upon how many individuals have been infected and recovered from COVID-19 in a particular area, but we can safely assume that we need to see about 40 to 60% vaccination rates coupled with the individuals that were already infected. Now, some people who were already infected are also going to be vaccinated. So you also then want to include that into your numbers. So it would be important. We still want to shoot for 80%. We still, even if you were infected with COVID, we still want to shoot for that 80% vaccination rate. I hope that helps to delineate it. It would be nice if we could get everyone to vaccinate, but that's wishful thinking. So we need to start to see a turn. We're going to need to see that 40 to 60% vaccination rate in a community.
Anybody else want to weigh in on that question before we move on?
I'm okay.
Okay, we're going to move on to the question of ripple effect, I believe. How can we use the information we're giving people to help them make choices surrounding exposure in our area to SARS-CoV-2? How can we avoid the ripple effect, I guess, is what we're talking about here, statistically?
Absolutely. So thank you, Chip, for that question. And before I jump into it, I just want to ask all our viewers at home, how many of you, raise your hand, even though I can't see it, raise your hand if you remember the ALS Ice Bucket Challenge. And it was all over social media, everybody requesting their friends and tagging them to participate. And obviously it was such a good outcome. One person would tag 3 friends, and then that person said, you know what, you tag 3 friends as well. And and it was for such a good cause to raise so much money. Now, both Jill and Paul mentioned the word exponential, like exponentially growing. What does that mean? So if we look right here, if one person said, let me tell 2 of my friends, and then they got a 3rd person, this is growing at a more linear rate right here. So it in the blue line, it shows the growth of people tagging each other is pretty linear, grows steadily at the same rate. However, if one person tags 3 people and then tags 3 people and then tags 3 people, that's exponential growth, where we are increasing the speed at which we grow over time, which is exponential growth. Unfortunately, COVID-19 works in the same way. So one person, if they meet 3 people, those 3 people can pass it on to those 3 people, another 3 people, and it grows, and it'll grow again. And by the 5th degree, one person could have passed a virus or could have passed something, passed it on to almost up to 243 people. And that's the effect one person has, if we're looking at how much impact you can make. Now, let's say we implement some mitigation efforts, if we all wear masks, or if just one person decides to stay home, we can almost, let's say this person decides to stay home that day, and so do these people, and so do these people. We can eliminate, that one person can eliminate spreading it to 81 other cases. So Jill, I think, refers to this also as the ripple effect, where our one action can have, especially in the time of COVID, can have a huge ripple effect and affect people we barely even know. And I think that makes the case even more for social distancing, wearing a mask, and limiting the spread of COVID. And that's all I had to add to that, unless Jill or Paul had anything else to add about exponential growth.
I think this just reiterates the importance of mask wearing and vaccinations. So we want to make sure that that one person, if the bottom third of this infographic from the first exposure, that individual was vaccinated, then we have the ability to decrease this spread over and over and over again. So we need to reiterate Tulsi's point in this wonderful infographic showing that you can do your part. So when it's your turn to get that shot in your arm, pick your non-dominant arm and get it right in that delt. We need you to step up because we all want to be able to go back to post 2019 COVID epidemic. So let's all do our part and get it in together.
Okay, I did want to just add one thing. I guess because there was such a high rise in, say, the early part of December, one thing I did notice, there was concern about a Christmas boost to case, like Christmas having another big ripple effect. The Governor Wolf, he did institute that one order that, we're in this, for December, the second half of December, where individuals could not go to restaurants or gyms. And that did seem to have a positive effect at curbing the number of new cases and deaths, say in January, though the level is still higher than it was, say, in October.
All right, thank you. That graphic was pretty telling, and I would remind folks watching the demonstration that you can ask questions in the Q&A box. A couple more minutes will be on. If you have a question, please, now's the time to push it through. In the meantime, I would remind everybody we're doing these every couple of weeks. So we've got a schedule coming up. It looks like this. On February 9th, we'll be looking at the issue of mental health as it applies to COVID-19. So I think that'll be a good session. After that, February 23rd, specialists, and we're going to be talking to people who specialize in different aspects of the disease. And we're hoping to bring in local leaders, talk about economic impact and education in the 2-week periods after that. So put it on your calendar. It looks like every other Tuesday evening, we'll be talking about a different aspect of COVID-19, and you're getting a lot of great information just like tonight. Not seeing any questions. Any folks on the panel want to offer kind of parting thoughts as we move forward? I think we've covered a lot of ground. At that point, I guess we'll turn it back over to Eric, who can take us home.
Thank you so much, Chip. Thank you. On behalf of Pitt-Johnstown, I would like to thank the panelists for this informed discussion. Thank you, Chip, so much for moderating. I do want to mention that Pitt-Johnstown designed social media frames that state "I choose vaccinations" for you to add in your Facebook avatar. It's kind of like what Tulsi was talking about in terms of the ice bucket challenge. We all need to advocate for vaccinations. We all need to be a part of this this important community effort. So I encourage you to go to simply change your Facebook photo, hit add frame, and if you type in "I choose vaccinations," you'll see our frames and you can add it into your Facebook avatar. And again, we encourage you to include that and be a part of this community effort. Like Chip said, please mark your calendars for February 9th. And on behalf of everyone here and this panelist, thank you so much for joining us.
Well, we do have some new questions, I see.
Oh, there's some coming in here. Yeah, there are actually.
Okay. One question is, what do the statistics look like when we hit max capacity at the hospital? Okay, well, I have been tracking hospital data for the county. Let's see, I have to look it up right here. So in terms of hospitalizations, the number hospitalized, so back in, so So the number of hospitalized, I'd say peaked at 114. That was back on December 15th. So that's when hospitalizations peaked. And, you know, at the same time, the number of people on a ventilator, okay, that peaked around, and that peaked around a week later. So yes, and okay, whoops, we did have some more peaks like in early January in terms of the number. So yes,
Paul,
we had about 114.
How many cases were going on at that time, Paul? When the hospitalization peaked, what was our caseload in Cambria County?
Our caseload. Okay, so here, let me go back. I have to look it up right here. So at that time, say on December 15th, we were averaging about 167 cases per day. I mean, the peak for the 7-day average for the county, that was on December 11th. So it took maybe like 4 days for hospitalizations to peak after we hit the peak for the number of new cases.
So what you're saying is there was a little bit of a lag between peak case numbers and peak hospitalization numbers.
Yes, and the peak, let's say the peak in the number of deaths, that peaked around 8.14 deaths per day. That came on December 17th.
So it was about a 14-day lag between caseload and death rate?
I'd say it's probably closer to a week. Yeah,
okay.
Like December 17th, December 15th, and December 11th.
Okay.
Yeah, Paul's right. We do have another question, and this feels like a Jill question, a Dr. Henning question. My husband just scheduled his vaccine with the VA. They allowed 4 weeks between appointments. Should it be 3 weeks? Do you want to talk about kind of the interval between vaccinations?
Absolutely. This is a fantastic question, and lots of people are concerned about that. So it goes back to the science of clinical trials. When we have clinical trials, we have a short amount of time, the shortest period between doses that is safe for humans or individuals who are being vaccinated. For the Pfizer vaccine, that shortest period happens to be 21 days. For the Moderna period, that vaccine, that shortest period is 28 days. But that does not mean that if you delay the second shot past the 21 days for Pfizer or past the 28 days for Moderna, that you will then no longer have any kind of protection. You're going to be protected after 2 weeks after the first shot, you'll be protected for about 50%. So that's why we still want you to wear your masks, practice social distancing, and wash your hands. After that second shot, it takes 2 weeks to reach complete protection from the vaccine. Complete protection from both of the mRNA-based vaccines is about 95%. So there are still people that may get COVID-19 after they've been vaccinated. But the good thing is that even individuals who did get COVID-19 after both doses of vaccination, the duration and the severity of the disease was significantly decreased. So you'll end up getting sick. You may end up getting sick, but you're not going to be in the hospital. But more to your point, if you have to delay that question, if you have to delay that vaccination, even just a little bit, it's okay. It's not going to affect anything associated with your immune response or the ability for the vaccine to provide you with a full portion of protection. It was just 21 days was the shortest time they found to be safe and effective after the COVID or after Pfizer vaccine. 28 days was the safe and most effective time for the Moderna vaccine. Scheduling it out farther is not going to create any issues or problems.
And our question poser did say it was a Moderna vaccine in his case that he was asking.
Well, even better, because the Moderna vaccine is 28 days. So you're good to go with that 4 weeks out.
All right, thank you very much to all of you. Eric, I think we're ready now to actually wrap up.
Yeah, we're actually going to finish. Yeah, no, I mean, I think there's going to be some additional questions that are going to come in, and we are taking questions in this together, Cambria@gmail.com. This is an ongoing conversation. We're going to continue to have and answer questions. We're collecting questions through the Gmail account, but also we're collecting through the Facebook page in this together, Cambria. So let's continue to share questions. This is an ongoing conversation. And thank you all for this. Thank you, panelists. Thank you, Chip, for moderating this important panel discussion. And again, everybody, please check those Facebook frames and pencil yourself in for February 9th. And thank you. Thank you all very much.